What should your primary care network be doing about enhanced health in care homes as we move through into the 21-22 tax year? Well, we'll be trying to answer that question in this video, which is part of a series of document walkthroughs as eGP Learning explore the requirements and responsibilities for primary care networks moving through to the next year. So buckle up and let's get going. So thanks for joining us for this document walkthrough. As ever, this isn't really a replacement for reading the document yourself, but I can find these documents quite daunting myself, and I find actually these videos really helpful for where I haven't picked up a document to provide a good introduction to the document, its structure, and really highlight those bits that are important and where I should focus. So this is the Framework for Enhanced Health in Care Homes version 2. There is not a new document for 2021, so what we'll be doing today is going over this document, which was published last year. I'm sure we've all done a lot of work on the content of the document and delivering it, but it's a really good time as we move into the next year to reflect on where we have got to. So I'll be going through with an eye on what we should be doing going forwards, but also reflecting on what we've done looking backwards. And it might be interesting for those of you out there to hear about what we've been doing in Nottingham and Nottinghamshire with regards to our work in care homes. So this is a really, really big document, and I think the important thing to say about this document is not everything in it needs to be done by primary care networks. And actually towards the end there's a table that sort of breaks out the responsibilities for primary care networks in Appendix 1. So we'll be spending some time with that table. Lots of the content of the document talks about good practice for the care of people in care homes, and a lot of these practices will be the responsibility of services commissioned in parallel to primary care networks. So your quite standard services that have probably been in place for a long time, looking at speech and language therapy, dietetics, and all of these things. So don't read the document worrying that primary care networks will suddenly be responsible for everything. Those services already commissioned by CCGs should continue, and the actions of primary care networks should be in addition to those. So let's start to move down, and as ever with these videos, we're going to scroll through the document and pick up where we think something is of interest or is important. As I say, we'll all have our own ideas about what's important. These are just my thoughts and my reflections from my own personal experience of the document and doing some work on this topic in my area and in my own primary care network. So section 1 is the introduction, which talks about the previous work that's been done in the area of care homes and how this document came into being, essentially. The key thing just picked out here is that primary care networks should not be replacing those services already commissioned in care homes. CCGs do need to continue those, and the work of the primary care network should be in addition and to enhance those services. So it shouldn't be used as an opportunity by CCGs to decommission services that are already there and providing care. So after the introduction, I move on to section 2, which is the principles of a successful enhanced health in care homes model. And again, this is quite descriptive, but really focused on 3 or 4 sort of core principles that they've defined as critical for success. So they want care to be personalised, taking into account the special circumstances and needs and wishes of the individual. Strong emphasis on co-production, that this isn't something that primary care networks or any one organisation will be doing alone, and that it will be co-produced with other partners in the health and social care community and commissioners. The CCG needs to be involved as well. Key stakeholders are obviously going to be your community geriatricians, which might actually be supplied by secondary care, and the existing nursing and allied health services and pharmacy services commissioned by the CCG. So obviously, they want a focus on quality, and they're highlighting the importance of strong leadership to make all of this work. Section 3, moving on to that, this section talks about the implementation of the framework. And in terms of the point that we're at, a year in, and now delivering these services, I'm not going to spend too long looking at that section. However, it does just highlight that this framework is not just for primary care networks, and it's going to be of interest to all of those organisations providing care to residents in care homes. So Table 1 is one of the sort of key tables within the document. In fact, there's only 2 tables within this document, this table and Appendix 1. And if you don't look at anything else within the document, then I would spend some time with these tables. Table 1 sets out these key elements and sub-elements of a really good model for enhanced care in care homes. So it's worth just spending some time with that. So important when looking at this table, as mentioned before, it's not the expectation. I don't read the document with the expectation that everything is the responsibility of primary care networks. Much of this is already commissioned by other elements of the health and social care system, so we don't need to be thinking that as primary care networks we need to deliver all of this. But essentially, they're hanging the requirements on 7 key elements, which are enhanced primary care support, forming and coordinating the multidisciplinary team. There's a talk about falls prevention and re-enablement and mobility. There's a focus on palliative care, end-of-life care, mental health and dementia care. Big focus on collaboration between the different elements of health and social care system. A focus on workforce development and in particular training and learning, and on the data and IT technology requirements that will be there and needed to ensure good information sharing and clinical governance in the near term, and accessing and using technology to improve care and care delivery in the future. So that's an important table. The next table, which I think we'll just nip down to and have a look at before we return to the document to get a little bit deeper on some areas. So this is the most important table in the document, Appendix 1, because this really sets out the requirements rather than aspirations to best practice, which are really important and form a lot of the rest of the substance of the document. But these set out the requirements of both the primary care network and of other partners. And this really separates out on the left what primary care networks need to be concentrating on making sure is happening, often with partners, but what they need to concentrate on making sure is happening, and then how other providers are obligated and compelled to support that. So, and it's not too big a table. So all of these deadlines are in the past. So these are things that should be operationalized and we should be doing them. And as we go through, I might reflect a little bit on the processes where I work in Nottingham. So care homes should now be aligned with PCNs and aligned with practice. So we went through a process in Nottingham, supported by the locality team in identifying care homes, identifying what was felt to be the natural home for those care homes within a PCN's geography. And then there were some care homes which were sat on the board and it wasn't quite clear within which PCN they perhaps should be located. PCNs have very defined geography, but there were some situations where actually they were within the geography of one PCN, but geographically much closer to practices within another primary care network. They might have had the majority of their patients already registered with a practice in another primary care network. So there was some debate about where these care homes landed. So there was a large alignment process that went on at the PCN level. And then later, in order to enable that each care home had was connected with an individual practice within the primary care network and had a lead clinician. Certainly in our primary care network, we went through a further process of deciding who would be the lead practice for each care home. And we did that as a PCN exercise. We came into it in a slightly unusual situation where, because of previous contractual models and previous enhanced services that had been in place, some of the practices had really, really high numbers of care home residents registered with them, and some had very few or even none in some circumstances. But actually, as a primary care network, we reached the decision that in order to deliver the best care to the patients. It was important that we didn't have some practices that were feeling overburdened with the responsibility of looking after residents in care home where others weren't. And we actually took the decision to share care homes across the primary care network on a fair share basis. So that was a really interesting exercise. So back to the document. Care homes need to be aligned within a PCN. You need to have a plan in place for the delivery of the elements of the enhanced care and care homes service. So hopefully that's in place and being operationalised. And these next 2 points are really about alignment, and there needs to be a plan and support for residents within care homes realigning with the aligned practice. And of course, each care home needs a lead GP or lead clinician to be appointed. This next section, again, deadline in the past, this should be operationalised, talks about the establishing of an MDT. So hopefully this is a process that's already happened. I know in Nottingham we already had MDT working really around care homes, and that was led by the community geriatricians. So this process involved partnering with them and the other commissioned services, such as the various types of nursing services and social care, to try and just bring those people together into a more formalised MDT structure, and just provide clarity on how often they are meeting and which care homes they're dealing with on each meeting. So we went through that process within Nottingham. Next section is just being clear that there should be information sharing arrangements in place between the different providers of care to people in care home and also with care homes themselves. So within Nottingham, a large part of this is achieved through the community hub, System 1 hub that we have in place, which is linked in and visible from GP surgeries and vice versa, providing the relevant information sharing boxes are ticked. So that works quite well with us. I think there's probably still a bit of work to make sure that care homes themselves and the information that they collect about residents is also plugged into that. So I think there's still a lot of room for improvement as we move forwards. So this next section talks about the home round, the weekly home round. So this is something, again, the deadline for establishing these is obviously well in the past. So this is something that should be taking place and should be fairly well embedded now, I think, and occurring on a regular basis. But the general principle is that a lead clinician, who is normally the same clinician for continuity purposes, along with relevant members of the MDT, conduct a weekly exercise within the care home. This can be done remotely, so this might involve a meeting on MS Teams, for example, pulling in the relevant people to talk about a list of residents. Now, it's important that this occurs at a set time within the week so that it is a predictable round. And these are the components that are described within the document. So there must be an exercise in prioritising residents, and there's a few ways that you can achieve that using risk stratification tools or the judgment of care homes or clinicians involved. So it must be prioritised. They talk about consistency of staff. So those people conducting the ward round should be the same over time. So same GP or lead clinician, same or similar staff from within the care home and from within the other elements, the MDT, who are going to be attending as needed. Continues to talk about consistent input from GP or geriatrician. And then there's a mention of digital technology. And I know my care homes are quite variable, really, in terms of how they like to engage with the home round. But certainly one of the care homes, we've got into a pattern where we have an MS Teams meeting and go through the residents via MS Teams. They do it on an iPad, and we can move and be mobile and move to residents' bedside if needed. And that works really, really well. So it's nice to see digital technology acknowledged within the document. The next section talks about the MDT arrangements. So, and sort of locally, we've settled on a sort of two-tier approach to our working around home rounds and MDTs. So there's a lot of activity within care homes which actually can be fairly simple to resolve and requires quite a sort of concentrated multidisciplinary team input. It might just require the GP, staff from the care homes, and perhaps an element from community care, just to focus on a simple issue and resolve it. Those happen quite frequently, but they are important. So we have sort of a weekly home round, which is based within the practices within the primary care network. Now, some of the requirements within this document for enhanced health in care home are more predictable, planned, and require a wider MDT input. So, for example, the MDT review of new patients entering a care home or re-entering a care home following discharge is something that can be picked up systematically, and is something that actually in Nottingham there was already a service commissioned to provide similar reviews. So that was that framework that already existed was utilised to create a sort of higher tier of MDT, which covers multiple care homes in different geographies across the city and provides sort of weekly access to a much more thorough MDT assessment that patients identified on the practice-based home rounds can be escalated to and receive a much better workup, and they also work up the new residents moving into the care home. So this section of the document talks about the requirements around the MDT. And then just a few final points. They do talk about identifying and engaging in locally organised shared learning opportunities. So that's quite flexible wording, I think. I think this is an area where we'd like to do more moving into the next year in my geography. We identify learning points on the home rounds and within the MDTs, and those are discussed with the care homes and the care home managers. But it would be nice to put more of a framework around that. I'd be really interested to see what people are doing in other areas around identifying learning, providing learning opportunities, and other things that they're doing in that area. So that sort of concludes a look at that table in Appendix 1, but I think that's probably the most useful and important part of the document. So let's just nip back up to where we left off and go through the rest of the document. But really, it's an in-depth look at the areas that comprise the table that we were just looking at. So let's just go through. So the rest of this video really will be focusing on giving you an overview of what's in the document and just a few thoughts on those so that you can dig in and go a little bit deeper where you need to. So, as I said, the next few sections really look at the elements in the appendix. So aligning care homes with primary care networks, I think that we've had a bit of a discussion about that and what's happened in my local area. We've talked about the home round as well as we looked at Appendix 1. Section 4.3 provides a little bit more in-depth guidance about the deployment of personal care plans and just makes it clear that they suggest that those are structured around the lines of the comprehensive geriatric assessment and include a structured medication review. They talk about the structured medication review and the application of that within care homes. Each of these sections provides a little best practice section, actually, which is really helpful for when you're designing or checking the specification of what you're providing. You can look at and aspire towards what is given as best practice. As we mentioned earlier, some of these areas are really not going to be the direct work of the primary care network, although it's important when we're doing our reviews of patients to ensure that these areas are being addressed. A lot of the instruction in the document is really for those other organisations providing care and support and the care homes themselves. So let's talk about hydration and nutrition. Let's talk about oral health, access to out of hours and urgent care. And this really sort of just outlines that should be available to care home residents, and they shouldn't be discriminated against because of their location of care, essentially. Section 5 talks in more detail about the expectations around the multidisciplinary team, and again gives some best practice guidance there. Here's a note just to remind me to talk about the sort of tier 2 levels of MDT and home rounds that have been established within Nottingham. So I think we discussed that already when looking at Appendix 1. 5.4 talks about continence, promotion and management. Again, important for primary care networks to be aware of the importance of this, and that this is discussed where relevant on home rounds and interactions with patients, but a large part of specific services will be commissioned elsewhere, I think, in most areas. There's a discussion around flu prevention and management. I think there's real opportunity here now that care homes are aligned with individual practices, and we don't or shouldn't have care homes where we have residents registered with multiple different practices. That should streamline the ability of practices to get a team into care homes to do their flu vaccinations, do all of the residents that are eligible and not declining of flu vaccines, and get out. So it shouldn't mean that care homes are having teams from different practices going in different days. That should make it a lot easier for people. And it's also interesting that the document does make some suggestions in terms of what care homes should do in different areas, and this is one of them, and they're suggesting that each care home should identify a member of staff to help coordinate the flu campaign. And I think that a lot of care homes do that, and they work with our staff at the practice to get paperwork ready before our team go in. But it's nice that the document places some responsibility on care homes. 5.6, leg and foot ulcers. We're just whizzing through here. Helping professionals navigate the health and care system. Talks here about the use of care coordinators, and I know that we'd identified this as a specific area where we thought a care coordinator could do a really good job of helping the residents and the carers who are often acting on their behalf get to the right part of the system as quickly as possible. That queries that could be addressed, for example, by a PCN pharmacist or by a separately commissioned speech and language therapy service, for example, don't necessarily come to the practice and to a GP to be redistributed out to those places, as can sometimes happen if requests and tasks aren't directed effectively, that those could go to a care coordinator, for example, and be immediately distributed to the right place. So some excitement about that in our area. Talk about falls prevention and mobility issues. And then another large area is around palliative care and end-of-life planning, and that is really, really important. Just really, this section highlights what I think is already good practice in terms of identifying people who should have some sort of end-of-life care planning in place, and using sort of locally agreed systems and tools for identifying and flagging those people up within the system, both to the GP providers but also to out-of-hours providers and other people who might be involved in their care. There's a section talking about mental health and also about dementia care. As I mentioned earlier, I think it's a big document, and just having a knowledge of what's in there is really, really helpful, so you can dive in when you're designing or dealing with the individual elements and go a little bit deeper on those. So, here's just a note. This section talks about the co-production, which again is a theme within the document. And this was just a note really to just remind me that I think as we move into year 2 within Nottingham, we've had a working group working to deploy the service over the last year, and I think it might be helpful for us now to think about evolving that working group into perhaps more of a provider forum, and perhaps expanding the membership a little, and turn this into the sort of forum that can help with ongoing good management and care of patients in care homes. There's a section about the contractual mechanisms. section about housing. Again, this isn't all directly for primary care networks. And then a section about developing the workforce and training and development. The final section, and I think this is something, having just gone through it, that Gandhi and I should probably do an individual episode and discussion about, because I think there's loads and loads of potential here. This section looks about data, IT and technology in care home, and really harnessing those things to improve the delivery of care to those residents. I just highlighted here that sometimes it begins with really basic things. As we found over the course of the year and responding to coronavirus with text messages proving to be really, really helpful. There's a lot of mileage in getting the basics right. So just making sure that care homes have NHS email, or at least email that is of sufficient security and clinical governance standards to work alongside NHS email for sharing of information. Some of our care homes have access to MS Teams, which is really, really great and opens up a whole opportunity to do all sorts of things via video that wasn't there before. There's something about getting the basics right in terms of Wi-Fi and even telephone coverage within care home buildings, so that just the basics work and that you can actually, if you're wanting to do a video consultation with a patient, that the wireless device actually works within that patient's room, for example. So let's not forget the basics. But there's all sorts of opportunities around Telecare, so that's the remote monitoring type technologies, around telehealth. So that's a lot of overlap with these terms really, but my understanding is that that's more the communication of sort of real-time data with healthcare providers and telemedicine. So this is about video technology with carers or with residents to help make decisions about their care. So that brings us to the end of the document. We're back at the appendix, which, as discussed earlier, is probably the most important part of this, and that's where I'd encourage people to focus their time if they don't have a great deal of time to spend with the document. It's been food for thought for myself, reviewing the document and the requirements, and I'll certainly be going back to the care home working group, with some suggestions as we begin to look at what we're doing in Nottingham moving into the next year. Hopefully that's been helpful. As I say, this is part of a series of videos looking at the responsibilities and requirements in various areas for primary care networks. So look out for the rest of those videos, and hopefully I will see you soon on more EGP learning content. Please follow, comment, and engage. Thank you.